All right, good morning. We're at another practice question focused on the lungs. This is helpful for your Step 2 CK, IM Shelf, or IM COMAP, and let's jump into it. As always, go ahead and pause, answer the question for yourself, and then we'll go ahead and jump into it. So this question in particular I've seen in a lot of different scenarios on several QBanks, and it's very helpful, this style of question, to understand. It's something that I kept missing, and so I wanted to make my own question trying to cover it. I'll go ahead and highlight some of the key details. Just to give you an overview before we do that, we're looking for a VQ scan in this patient presentation. So you really got to know what values are changing. So I'll go ahead and highlight it. So we have a patient who just went under hip surgery, which whenever you see that, recently had surgery, recently traveled, or recently became immobilized, they're all indicating that the person's become inactive. And that plus dyspnea, pleuritic chest pain, and a high respiratory rate is just screaming PE, pulmonary embolism. Because respiratory rate, because of the alkalosis that happens, they're breathing really fast, respiratory alkalosis, and so, brings down their CO2 levels. And so the question is essentially asking about the 65-year-old male who now has a PE as he comes to the emergency department, and they want to know what the VQ scan is. So now you're looking at these answer choices, and sometimes you might think, man, I have no clue. But I'm just going to take a step to look at what exactly is going on in the lung, and maybe that will help us answer the question. So here's a picture I kind of pulled together. And so a pulmonary embolism is when you get an embolus that comes into either from the heart or somewhere else, but eventually it gets to the pulmonary artery and it's going to lodge itself. So if you think about that, you get this embolus that's now lodged, and this is in the blood system, right? In a vessel, you are going to block blood flow to somewhere in the lung. And so what that does is that's going to cause perfusion defects, because you're not going to be able to get blood where it needs to go. By contrast, the lungs are still getting oxygen from the trachea, when you respire. And so ventilation is going to be totally fine. So here we have an embolus, comes up, could be from a DVT, could be from a PFO, could be from all kinds of things. But it comes up, gets into the pulmonary arteries, lodges somewhere, blocks off blood flow. So this is an x-ray you might see relating to that. So now going back here, it makes it pretty clear that we're going to want to be looking for something with decreased perfusion but normal ventilation. And so that option is D. It's the only one that shows impaired blood flow or perfusion defects with normal ventilation. We can go over some of the other ones just so you can see what situations might have those. So A, multiple areas of matched ventilation and perfusion defects. This isn't the typical presentation of a PE, as we just mentioned, because PE usually has well ventilated parts and then poorly perfused. And also based on the patient's presentation, the symptoms of dyspnea, pleuritic chest pain, it just makes A wrong. Normal ventilation and perfusion through both lungs. This would be someone without any problem. So this would be someone without a PE. So they wouldn't be presenting to the emergency department. This would be someone who's stable and isn't having any ventilation problems. But since we know of the embolization from the surgery and the sudden onset of dyspnea and pleuritic chest pain, we know that PE is a more likely diagnosis. Option C, ventilation defects with corresponding normal perfusion. This is the answer that I always sometimes mix up, whether they're testing pulmonary edema or testing pulmonary embolism. So you really have to keep those separate. Just remember back what we had here. The embolus lodges, blocks the blood flow, whereas in pulmonary edema, you get a buildup of fluid in the lungs, so that's making it difficult for the oxygen to pass through the lung to oxygenate it appropriately. And so because of that, you're getting ventilation defects where it doesn't affect the vascular supply. So contrasting that, instead of having these emboli blocking here, you'd have normal supply here, but then you'd have this fluid in the lung. So just imagine this dark part being fluid that would be blocking oxygenation. So that would be pulmonary edema. So C, ventilation defects with corresponding normal perfusion. That would be present in pulmonary edema, whereas D, perfusion defects with corresponding normal ventilation, is more indicative of a PE. And then E, diffuse increased perfusion throughout both lungs. That's more consistent with things such as high output heart failure or AV malformations, where there's an increased flow of blood through both lungs. So in summary, the most likely finding on a VQ scan for a patient with a clinical presentation of a PE, as described in the question stem, sudden onset dyspnea, pleuritic chest pain, tachycardia, and those other risk factors, is perfusion defects with corresponding normal ventilation, option D. All right, there you have it. As always, please like and subscribe and comment the kind of questions you'd like to see in the future, and that's it.